show you what the things I would normally look at and the way I would have reported it. And then we'll just do a sort of a small Viva session with candidate one. The candidate one already has the control. So what I'm going to do is just give you a little bit of history. So this patient is a young patient, 24 years of age, and presents with a twisting injury whilst playing football. So this is the MR scan of the knee that we've been given, and here you go.
Okay. So this is a sagittal PD fat set sequence of the right knee. Sorry, I'm just trying to scroll through. It's a bit slow. Okay. So I can see there are bony contusions demonstrated on the anterior femoral condyle and posterior tibial plateau. And that's on the medial side. Make sure the images. Okay, so I can see the PCL, which is intact. I'm just going to look at the ACL as well. Okay, so there is the ACL appears swollen and enlarged. There is bony contusions along the tibial insertion point of the ACL. So at the moment, I'm concerned about a ACL sprain. I'm just gonna review the rest of the images. Okay. Right, so going back to the ACL, so there's discontinuity of the ACL fibers, particularly at the femoral insertion point, attachment point. So I'm at the moment worried about a ACL tear. There is a small volume of knee joint effusion as well. The PCL is intact. I'm just going to have a look at the coronal view as well. Yep, so there are bony contusions on both sides, the medial and lateral aspect of the femoral condyle. And there is some soft tissue swelling over the lateral knee joint. The menisci appear intact. I'm just looking for any obvious osteochondral defects, which I don't see. So in essence, so there is bony contusions on the medial and lateral aspects of the femoral condyle, and also posteriorly on the tibial plateau. There's discontinuity of the ACL fibers, particularly at the femoral attachment point. Therefore, appearances are consistent with a ACL tear. And yeah, I'll be contacting the orthopedic team to make them aware of the patient.
Okay, good. The only thing I would say that I want slightly more confirmation is your ACL tear. Do you think it's a partial thickness tear? Do you think it's a full thickness tear? Or is it a sprain, as you said initially?
I think it's a full thickness tear because I can't see the fibers on the posterior aspect clearly. So I think it's a full thickness tear.
Okay, and of the femoral attachment, as you said?
Yeah.
Okay, So we'll take the control back. I think I can take the control back, stop remote control, so it'll be easier for me to scroll through. Right, so that's a good attempt, but of course it's only less than half the attempt you would expect in an exam situation. So there are lots of findings that you need to pick up. And of course, in an exam situation, we completely understand there'll be lots of pressure on you. And because of that pressure, there's an urgency to quickly run through the images. Now, remember, in most of the exam situation, there'll be multiple findings, and you have to correlate in your mind everything together. That's what we always tell our registrars, how you're going to correlate everything together. So I will go through the case with you, and I'll sort of in between also tell you how I would have looked at it, because remember, it's also an art to present, because in an exam situation, you've got to know the findings, pick them up in a very short span of time, and then present it to the examiner. So that's what we're going to do. So I normally start by dividing, in this particular case, into two screens. Of course, when we're doing it on our PACS monitor, we have about 8 different screens demonstrating all the images. But let's assume if I had the option, what would I show first, or what would I look at first? I would always start with the sagittal PD sequence, because that's the most important sequence, which will show you almost all the pathologies. Of course, it will reduce the intensity of the bone marrow edema that you'll see in the bones, but then you've got T2, you've got T1 sequences to look at. So we will, of course, look at all of these sequences. But if I was to start with one particular sequence, I would normally start with the sagittal, and I'll normally start from lateral to medial, so I can look at the structures I always look at. And on the other side, I'd normally bring up the coronal as we've given you, so you can actually cross-reference things, because if you're not sure about one thing, you can always go to the same area on the coronal scan to see if what you were looking at on the sagittal is actually a true finding. So let's look at the sagittal PD sequence on this side. And the first sequence, the first initial sequence from the lateral side, you'll see this dark structure. It'll be a sort of what we call a Bugs Bunny appearance. In other words, you see 2 black ears. So that's the biceps femoris, and this is the lateral collateral ligament, and you can see the fibular head. So this is a really important sequence, because if there's lots of damage to this on the first sequence, if there's lots of edema, you start thinking about ACL immediately. So that's the first thing I would go for. And as I move centrally, I immediately look at the femoral condyle and the posterolateral tibia. And at this point, this is the most important finding. Even without doing anything, I can tell you now that this patient has got a complete ACL tear. Why? Because of the contusion pattern. Look at the bone marrow edema of the lateral femoral condyle and the posterolateral tibial corner, perhaps subtle marrow edema of the fibular head. So you can straight away tell that there's damage to the ACL. What extent? We'll come to in a second. At this point, I also cast a quick eye on the lateral meniscus. Now, as Dr. Butt was telling you, you can see a nice triangle of the lateral meniscus there, except for a little cleft here, which I'm not sure about at this stage, but remember, we've got a coronal sequence at the same time on the other side of the screen that we are looking at. So let's just have a quick look at the coronal to see if there's anything there. And can you see immediately there is a vertical cleft here that you can see. Now, this should have been a nice contiguous triangle all the way and then heading back. So there's a clear vertical cleft here of the lateral meniscus. That's again another pointer that there's something going on, which is multi-ligamentous, which is a sort of a twisting mechanism fit injury. Okay, so we've already confirmed one finding. We've already suspicious of a ACL tear, and we keep moving centrally. And as I keep moving centrally, I will still look at this, at the back of this particular aspect of the lateral tibial plateau, because you don't want to miss a fracture here. If you miss a fracture here, then it'll have long-term posterolateral pain associated with it. So of course, I can't see any obvious fracture, but I wouldn't rule it out at this stage, because remember, we've still got T1 to look at, and fractures are better picked up on T1. Of course, this is just a guide to tell you that there is something going on in the bone. So keep going centrally, and what do you see here? Well, clearly there is an abnormal signal intensity as you very rightly said, you initially thought it was a sprain because there was abnormal signal. Remember the anteromedial and the posterolateral bundle of the ACL. But the problem here is more than just high signal. Although the orientation of the ligament is well maintained, there's something not right at the tibial foot plate. Now, you did allude to it. You said that there was a bit of marrow edema here. But in addition to the marrow edema, look at the shape of the fibers of the ACL. Why is it curving around? It shouldn't be. It should be a nice taut structure. And all of the edema is centered here. So you can't really make out, but I would be really suspicious that there's something going on at the bony foot plate. Another word, an avulsion fracture is what I would be thinking of, the tibial component, not the femoral component, because the femoral component actually you can still see parallel to the Bluensatz line, which is the roof of the intercondylar notch. So the problem seems to be here, but of course we will confirm all of this. You can see that here. Now, whilst we are looking at that, why don't we look at the coronal, because we've got it there on the screen. We might as well just have a quick look at the coronal. And this intercondylar eminence of the tibia does not look normal, because there should be a nice sharp margins of the tibial spines in the intercondylar notch, and all of this marrow edema needs to be looked at. And we will look at the T1 in a second. So here goes the ACL, and you can see that there is lots of edema. Now that brings us, whilst we're looking here, so ACL, we're highly suspicious that there is an underlying avulsion fracture of the foot plate, or at least a full thickness tear of the tibial foot plate of the ACL. The next structure, whilst in the intercondylar notch, I would look at is the PCL. And why? Because of two important reasons. One, I would like to look at the shape of the PCL. Is it a nice, smooth, convex shape, or is it like this? Is it a hook shape of the PCL, which is what we call the shepherd's crook deformity? In other words, this is buckling of the PCL. So that, again, gives you a very good indication that there is an abnormal ACL. So if you look at the structure, the PCL, normally the PCL is black on all sequences. It doesn't matter whether you're looking at the PD, whether you're looking at the T2, T1, it's always black on all sequences. Why is it gray? That's not right. So which means that this ligament is also damaged. Of course, it's not torn because it still maintains its femoral attachment, tibial attachment, but it's got an abnormal signal, which means it may have a partial intrasubstance tear. And again, if you look at the coronal, this is the PCL. And if you look at the coronal sequence, it should be nice and black. You should see a round black structure lying in the intercondylar notch. If you see a gray structure, as you're seeing here, that's no good. That means that there is an intrasubstance abnormality of the PCL. So you've already, even halfway through the knee, you haven't even gone towards the medial side. You've already picked up an ACL avulsion tear. You've picked up a partial intrasubstance PCL tear. You've already picked up a vertical cleft tear of the body of the lateral meniscus. You've already picked up the bone bruising. Now, another important thing that whenever I look at the PCL, I would immediately, even if there's a hint of partial tear, I'd look at the posterior joint capsule, and I would look at the popliteal vessels, because if there's any damage to the PCL, the posterior joint capsule gets damaged, you get transection, or you get injury or dissection of the popliteal artery. So if normally we would say look at the flow void, but of course this is a PD sequence, so you'll see the vessels to be bright. So you look at these vessels and to see if the outline is normal, if the flow is nice and homogeneous throughout. But that's for more for PCL. Here we are more suspicious of a complete ACL and some PCL injury. We keep going now towards the medial side. So again, you can see as we come towards the medial side, this is the root of the posterior horn, the medial meniscus, which Dr. Budway elegantly demonstrated. And as we come peripherally towards, you can see that there is bone marrow edema, as you pointed out, of the posteromedial tibial corner and the medial femoral condyle. Why is this important? Posteromedial tibial corner. This is really important because this generally implies, if you see marrow edema here, I always think, is there a small peripheral tear of the posterior horn of the medial meniscus at its junction with the meniscal body? Now, I'm not entirely convinced it is there, but I would normally be suspicious. So I would look harder on the coronal sequence at the same time to see what's happening with the peripheral meniscocapsular junction of the posterior horn and the medial meniscus. Now, there's a bit of high signal. I'm not entirely convinced this is real or not, but a ramp tear this is the area where you look for a ramp tear. Now, a ramp tear is a sort of a vertical tear of the junction of the body with the posterior horn or the capsule. And this is generally what happens is because of the mechanism of injury, this meniscus pops out, hits the back of the tib and goes back in. And as it does this, it causes a vertical cleft tear. So in any case, we will look at it. I haven't convincingly seen any. So on the medial side, but we picked up the bone contusion. So that's your sagittal PD done. And that's pretty much answered almost all of your findings. Almost, I said, not all of them. Because there's one thing left in this twisting mechanism of injury, as you would have heard in the lecture. Of course, I joined a little later. But whenever there is twisting injury, there is the risk of damage to the central core structures, which is, of course, the ACL and PCL. There's a risk of damage to the posterolateral corner and the lateral meniscus. There's a risk of damage to the medial meniscus, but there's one other thing which is left, which is also at risk, which you can't really see on the sagittal, which is the medial collateral ligament. So we need to look at the medial collateral ligament. And for that, we have to go to either axial or the coronal sequence. So let's go to the coronal, which is already there. So let's just look at that. So the first thing which catches my eye is that there is lots of edema and thickening of the superficial MCL. Remember, this MCL has got multiple parts, 3 parts. This is the superficial part. Normally, it should be a thin black line. You can see it's not thin. It's at least 2 millimeters thick. There is edema on the deep surface. There's also edema on the superficial surface. This gray structure is called the meniscofemoral component of the deep MCL, which always gets damaged, especially in a twisting injury. So you can see it's not a thin black line like here, which is the meniscotibial component. Remember, of the two, whenever you're seeing knee, the chance of damage is highly likely to the meniscofemoral, very less likely to the meniscotibial. So you can see the meniscotibial is nice and beautiful, nice black line, but this is gray and thickened. So you've already ascertained that there is damage to the MCL. Of course, it hasn't disrupted. So a different grading system, you don't have to remember, but if it's only stretched and edematous, it's grade 1. If the fibers are partially torn, or if there is some disruption of the fibers, you call it grade 2. And if there's complete avulsion, you call it grade 3. So here you can clearly see there is no avulsion. There is no disruption of the fibers, but it's just edematous and thickened. So clearly this ligament is sprained, or we call it a grade 1 injury, if you want to call it. You can see the tibial attachment. You can see the tibial attachment. Remember, it goes way down, almost 5 centimeters or 7 centimeters below the medial joint line. So we pretty much answered all the questions. Do we need to look at any other sequence? Yes, we do need to look at other sequences. And I'm just going to bring a T1 weighted sequence up here. Why? Because we want to see if there is a fracture or not. So let's start again from the lateral side. Now here, I'm only interested in fracture. I'm not interested in anything else. So it is this area that I'm slightly concerned about on the T1. Can you see that little step here? And let's go to the midline where we are very suspicious that there is something going on here, because this is not the normal shape of the intercondylar eminence. So we are suspicious on CT, on MR, that there is a problem. So normally what would I do? I would recommend that this patient have a CT. And the reason why it's important for them to have a CT is that we want to see if there's an avulsion fracture, because it may require fixation. But before I go and start asking for a CT, I just want to have a quick look at the axial sequence. Now, the axial sequence is really important for multiple reasons. You've already on the sagittal seen all the central bits, but what you haven't seen is what's happening at the front of the knee. And the front of the knee is a whole separate structure called the extensor mechanism, or the extensor apparatus. Now, the extensor mechanism is this quadriceps, the patella tendon itself, and of course we look at the cartilage at the patellar surface and the femoral trochlea. So if I quickly run through it, I know we push for time, you can see the cartilage is nice and smooth, so there's no chondromalacia patelli change, but I can certainly confirm the MCL attachment of the femoral attachment of the MCL. So that's really gone, or in other words, not gone, but edematous. So that's damaged. You can see the ACL in there. You can see the PCL in there. It'll actually give you a lot of information. And this is where the problem is, which we think is probably an avulsion fracture. So normally, when I look at the axial, in addition to chondromalacia patelli and all the patellar maltracking that Dr. Sajid Bhatt mentioned to you, I would also look for any joint effusion, which you don't see here. On the sagittal, I would quickly cast an eye at the superlateral margin of the Hoffer's fat pad to see if there's any impingement. And also, I would look at the back of the knee to see if there's any popliteal or Baker's cyst. And of course, I would normally look at the popliteus tendon because this usually gets damaged or edematous in ACL and PCL injuries. So axial is very good for looking at the ligaments on the side, the front and back. And of course, you can see the popliteal vessels flow void. So we pretty much in 5 minutes or 6 minutes looked at all the structures. I always follow the same sequence. From lateral to medial, bring the coronal up, cross-reference on the coronal, bring the axial up, bring the T1 up to exclude fractures, axial to look at the extensor mechanism, chondromalacia patelli changes, and back of the knee to look for any Baker's cyst. So in order to confirm, we have to look at the CT. I've just stopped sharing because I need to bring up the CT of this patient. Oh, hang on. Share. So this was, okay, I'm just going to bring this up. I'm going to stop share and then reshare again to see if we can actually see the CT. Okay, this is the CT of the same patient. Let's just go from the lateral to the medial side. What catches your eye immediately is that there is a bone fragment there. There is a step deformity here. So this is a non-displaced fracture of the posterolateral tibial plateau. There is an avulsion fracture, which is a bone fragment sitting at the back. And of course, as you go towards the middle, voila, there is the avulsion fracture of the tibial footplate of the ACL. Now, the question is it really acute or is it subacute? I think it's probably subacute for the reason that there is no joint effusion. It's highly unlikely you fractured something and there's not a hint of any significant effusion. There's not a hint of lipeme arthrosis, as we would expect there to be. So there's probably an acute on chronic. The ACL may well have been damaged previously, but the patient has had a twisting injury. That's why he's got the bone bruising on the lateral side. He's torn he's got a cleft ear of the lateral meniscus and he's damaged the MCL, which we know is acute because there's lots of edema. So this is how I would attempt. And in my summary, I would say to the examiner, the appearances would be consistent with an avulsion fracture of the ACL, which may well be long-standing because there's no joint effusion. However, there is an acute element which involves edema of the MCL, which is a grade 1 sprain, and bone marrow edema at the lateral femoral condyle and the posterolateral tibial corner with an associated vertical cleft ear of the lateral meniscus. So this is more like an acute and chronic picture. End of story. So you need to summarize at the end, as you did. I did notice that you did bring a summary to us as to how you would attempt it. So I think that's the first case. I'm going to stop sharing. And
Babar, can we go to candidate 2? So
correct.
Babar, don't worry about, should I say, quantity. I always say quantity is not important, quality. And the way I think everybody learns so much from this single case. So even if the last candidate 2 is our last candidate, even she sees one case or 2 cases, the quality which you are giving, that is brilliant.
Excellent. Fine. We will carry on with candidate number 2 this time. So I'm just going to first share and then give the control to candidate 2. So I'm going to share.
Thank you, candidate 1.
Yes, that was very good. Well done.
Thanks.
Remote control. Right, here you go, candidate 2. You've got the control. And can you just confirm that you have the control? Yes, you do. I've brought up the same sequences. So this is a 26-year-old, again, with a similar sort of twisting mechanism of injury. And the case is all yours.
So on this PV fat set sequence MRI of the knee, looking at the sagittal lateral compartment, there is significant bone marrow edema in the lateral femoral condyle. and a knee joint effusion. So it's a bit lagging, so I'm just still scrolling slowly.
Can I add this patient had a motorbike accident?
The lateral meniscus is intact with normal morphology. And the ACL fibers appear intact. There is a tear in the posterior cruciate ligament at the femoral attachment, which is a complete tear. The medial meniscus appears normal on the appears extruded anteriorly, but I don't see a tear at the moment. There's no significant bone edema in the patella, so I would like to proceed with the coronal sequence. So starting from lateral, the bicep femoris tendon and appears intact.
Can you point out for the clarity of the people watching? Excellent, very good.
There is abnormal signal in the lateral collateral ligament,
Just point
which I can't hear. I wonder if that's part of the capsule. I'm trying to distinguish that from the lateral collateral ligament. So actually, I think the lateral collateral ligament is probably okay. So that's probably just the capsule. So again, the torn PCL is noted, and there is, I mean, the menisci is normal other than slight extrusion, which may be related to posterior displacement of the tibia. The medial collateral ligament is torn and with significant soft tissue swelling around it. I would like to also assess the knee on the T1 and the axial PD flat set sequence. But I can summarize the findings.
please.
Okay, so there's a complete PCL tear with lateral femoral condyle bone contusion with knee joint effusion. So this is in keeping with a dashboard injury with a complete PCL tear.
Okay, so we'll take the remote control back. Well done. So in summary, it was a dashboard injury with rupture of the PCL. So good, you did very well in the sense that you quickly picked up the things that I've just noted on the previous MR. So you're sort of going through the same routine, which is excellent. However, if somebody had a dashboard injury, where would you expect the contusion to be? What does dashboard mean?
Usually that would be patellar bone marrow edema with the anterior tibial.
Probably not. And the reason for that is, remember, when you're sitting in the car, your knee's flexed. So the patella is way out of the way, sitting at the top. It's your tibia, which is sitting right at the front, which is going to take the brunt, because that's the bone which hits the dashboard. So if somebody gets a dashboard injury, this is where the bone contusion and bone marrow edema is going to be. Not at the patella, definitely not at the lateral femoral condyle, which is what you have, because that's the first thing which strikes me. When I start with my routine, remember I said I start with the lateral collateral ligament conjoint. Now here's your lateral collateral ligament. You can see it beautifully here, coming at an angle, joining the biceps femoris, forming the conjoint insertion. So actually this, the first sagittal gives you a beautiful view of the lateral collateral ligament. Now let's just confirm the lateral before we go anywhere. So this that you were probably mentioning is a very important point, because remember, you're only seeing part of the attachment here. There's still a little bit at the front that you're not seeing, because remember, it's a curving bone. So you may well be right that there is a little bit of high signal at the femoral attachment, which I wouldn't be surprised. Look at the huge amount of bone marrow edema at the lateral femoral condyle. So the most important thing for you to understand, can I ask you, if it's not a dashboard mechanism, what else could it be? What else could be the mechanism?
Pivot shift.
Okay, pivot shift is rotation. This is an impact on the lateral side of the knee. Why? Because all the marrow edema is centered at the lateral. So there's been an impact at this side of the knee. Remember, wherever you get the impact, you get massive bone bruising. On the opposite side, you get less bone bruising. And imagine if the force was coming from the lateral to the medial side, you'd get bone bruising here, but you will disrupt the MCL. Because remember, when the two bones are like this, if the force comes from outside, it'll open up the other side of the bone. So it'll open up this side of the joint. When this side of the joint opens up, you damage your MCL. So that's the classic lateral to medial force vector, which is acting on the knee joint. That's why you've got this pattern. This is classical pattern. Force is coming from here, lots of bone marrow edema here, less bone marrow edema here, but at the same time damaging the MCL. So because this joint has actually opened up and closed again. And that's why you don't see the opening up, but you've definitely now noticed the sequelae of the injury, which is the complete disruption of the MCL. So on the first, as I would normally start, if I just see lots of bone bruising of the lateral femoral condyle, I know this is an impact injury. It's not a twisting injury, for the simple reason that there is no bone bruising at the posterolateral tibial corner. So this patient has had an impact on the tibia, so on the femur. So let's follow our routine. So we've seen the biceps femoris, we've seen the lateral side with no bone bruising here, but lots of bone bruising there. And of course, we start looking at the lateral meniscus. So the lateral meniscus seems okay on the sagittal, but we can't be sure because we still have a coronal to look at. So let's just go through the coronal very slowly. We're starting at the front of the joint. And as we head back, we start seeing a nice triangle. Triangle. Is it still a triangle? Not really, because there is a little bit of blunting here. So remember, you may not see this bit of the tear on the sagittal because it's on the other side. It's exactly here. So there is a small blunting. It should be a nice triangle, but there is a little blunting here. So I would say that this is there. If you're not absolutely committed, you just say there's blunting of the inner tree margin of the body of the lateral meniscus, which may suggest that there is a small radial tear of the inner tree margin. So I would definitely make a comment, even if it's a negative or positive, make a comment, tell the examiner that you've seen this. You keep going back and the posterior horn looks beautiful, so there's nothing there. So we picked up two things. Let's keep going towards the center. The first structure that you will see is the ACL. So remember the anteromedial and the posterolateral. The ACL is definitely intact, but there may be some intra-substance signal. I would take it either ways. If you say there's a little bit of edema, I wouldn't critique you on that. I would say fine. But the ligament generally seems intact. The problem, as you very rightly say, is the PCL. Why? Because remember, it's not following the rule. It has to be black. It's not black. Not only is it not black, is it contiguous? No, it's not, because there's a disruption. So remember, the PCL has got different parts. It's got the femoral attachment, it's got the genu, and it's got the tibial attachment. So the genu and the femoral attachment is abnormal because there is abnormal signal and there is a discontinuity here. Let's confirm that immediately on the coronal. Is that a normal shape or signal of the PCL? And the answer is no. And the more you come forward, you see there is a gap here, which means it's complete. There should be a nice round black PCL looking at you at this particular slice. And you don't see that. What you see is a white structure, some black fragments, clearly implying that there is a complete disruption of the PCL. Remember the things I said to you. What do you do next when you look at the PCL? The most important thing you look for? Sorry?
The popliteal vessels.
Correct. So you have to look at the popliteal vessels. You have to look at the posterior joint capsule. Tell me what you see. Look at the posterior joint capsule. That's abnormal. It's diffusely thickened. It's diffusely edematous. This should be a nice margin that you should be able to pick up with your cursor. You don't. So that means that there is damage to the posterolateral joint capsule. But the good thing is the vessel looks pretty good. Why? Because the mechanism of injury is not front to back. It's medial to it's lateral to medial. If it was coming, if the force was coming from this direction, you could easily damage your popliteal vessels. But here they've saved because the vector is coming in the transverse plane. So it's coming from the wrong side. So there's no danger to the popliteal vessels here. But of course, it has disrupted the PCL. Now, the only question is there any avulsion of the bone? And the answer is no, because you can still see the black cortical margins. If there was an acute avulsion, there would have been lots of marrow edema of the site of attachment. So clearly that is not the case. So you keep going medially now. So you start seeing the root of the posterior horn, the medial meniscus. You look at the medial meniscus all the way, you confirm the medial meniscus. You can clearly see there's a bit of myxoid degeneration because there's clearly abnormal signal, but it's all centered within the meniscus. It's not going to the articular surface, so you cannot call it a tear. You can certainly call it myxoid degeneration if you want. And of course, why is the meniscus extruded? You kept mentioning that the meniscus seems to be extruded out of the joint, or at least anteriorly. And there's a very good reason why you should be able to justify that statement. Because remember, the meniscus is held in its place by the MCL. MCL has got the meniscofemoral, the meniscotibial components, the superficial. Should have kept some water here. So you can see, because this, the MCL, which also holds the meniscus, is not there anymore. It's completely disrupted. As a result, the meniscus extrudes. So that was a very important finding that you picked up, that the meniscus is extruded. But of course, the examiner may say, why do you think the meniscus is extruded? So you've got to explain. So whilst we are here, let's start looking at this MCL. What's going on with the MCL? So you see the tibial attachment. That's how it should be. Nice. But it starts to get edematous and thicken, and here it disrupts. So it almost disrupts at the level of the meniscus. And then at the femoral attachment, there's nothing there except for, it's just like a mince. There's hardly any fibers attached. I can't distinguish between the superficial and deep MCL. So I need to now bring up the axial on the other side because I want to look at this meniscus. Because remember, this is not, I need to look at the MCL because remember, it's not just the MCL which attaches here. What else attaches? The medial patellofemoral ligament. So the medial patellofemoral ligament, if I bring it up here on the axial, let's go up, is this structure which connects the medial femoral condyle to the medial patelloretinaculum. Remember that all of this is not the medial patelloretinaculum. It's only the part which attaches to the medial half. The patella is the medial patelloretinaculum. Beyond this, all of this is the MPFL, or the medial patellofemoral ligament, as the name implies. And the medial patellofemoral ligament has got a conjoint insertion with the MCL. So when the MCL completely disrupts, it damages the MPFL as well. So that's why you see it's all edematous, it's all thickened. So you've damaged the entire medial support of the knee now. So this knee is unstable. And this knee is unstable because there's nothing on the medial side protecting it. All of it is disrupted. And of course, the patient is lucky because the patella is not gone all the way on the other side, because there are probably still medial patellarachnoid fibers holding it, because the MPFL is not completely torn, it's partially torn. So immediately you can see, just bringing the 3 sequences, you've pretty much managed the whole case. You've picked up all the findings, you've understood the mechanism of injury, how this has happened. Because it's, remember, if you understand the mechanism, you'll pick up the relevant structures which are going to be damaged. Just in your mind, imagine what will happen to the structures if the force comes from outside. Now, if I was to reverse the force, if the force was coming from the inside of the knee, you will have lots of bone bruising here, very little bone bruising here, but you will disrupt the biceps femoris and the lateral collateral. And the typical mechanism is that the biceps femoris avulses from here because the lateral side of the knee opens up. So it's exactly the opposite of what you're looking at if the force was to come from the medial side. And of course, this is an acute injury for multiple reasons. There is bone bruising, there is lots of joint effusion. So there is a moderate joint effusion there. And of course, you've looked at the popliteal fossa. There is a little bit of edema here. Remember, the pes and psoas tendons are intact. So is the tibial attachment of the ligament. It's the femoral attachment. So what would I say in conclusion? In conclusion, I would say to the examiner, there is significant bone bruising of the lateral femoral contour, implying an impact site of the injury. And as a result, there's disruption. There is a grade 3 complete, if you don't want to use the word grade 3, use complete disruption of the femoral attachment of the MCL, resulting in extrusion of the medial meniscus. It has also damaged the medial patellofemoral ligament, which is edematous and thickened, but not completely torn. And there is no patella dislocation. This is a relevant negative that you're giving, that there's no patella dislocation. And most importantly, there is complete disruption of the PCL. So how do you treat PCL disruptions? Generally speaking, they, unless it's a bony avulsion, they tend to heal. So it's unlike ACL where you have to go in and do intervention. This generally tends to heal and scars and actually functions pretty well. But if it's an avulsion injury, then you have to go and fix that. Okay. So that's case 2. Have you got time for one more case?
Yes, please. We'll go for one more case. And all of the audience, you know, for your FRCR 2B exam, trauma cases are very popular. So whatever is being taught, this is classical cases, and they come as a long case usually. So multiple findings in trauma cases are the most usual knee MR. So Babar, very useful. Please take another. And even if you go slightly beyond 9, this is gold dust. So please continue. Take your time for one more case.
So I'll probably show you 2 short cases. We'll
Okay.
keep it. So each candidate gets another chance. So I will let me just bring up the case first.
So you want to take candidate 1 once again?
No,
Candidate 1, are you with us, please? Are you with us, candidate 1?
Yep.
Your case, please.
Okay, let me just bring it up. And I'm going to give you the control. Have you got it?
Yep.
Excellent. So here's another young man, and the interesting story here is that this is definitely a skiing injury.
Okay. So starting with the PD sagittal sequence. So I can see the conjoint tendon normally.
Can you point out?
So
I think we're on the medial side of the knee.
Oh.
That's okay. We've done this all so many times. There you are.
All right, so starting with the lateral side. Yeah, sorry. So that's the bunny sign of the conjoint tendons. Yep. So going laterally first. So there is significant bony contusion on the lateral femoral condyle. The tibia and fibula are preserved. There's no evidence of meridema there. Just having a closer look at the lateral meniscus as well. So I'm concerned about the posterior horn of the lateral meniscus because it's significantly smaller than the anterior horn. But I've not seen any evidence of an obvious tear yet, but I'm just going to have a closer look again. Okay, so there is high signal coming from the anterior horn of the lateral meniscus.
Is that what Dr. Butt mentioned to you? Remember, he mentioned a very important point about the anterior horn of the lateral meniscus.
Yes, I believe he said that if you see a meniscal cyst, ganglionic cyst, which I think that is what that is, you should be looking very closely for a tear. But additionally, you can get fluffy appearances of the meniscus, which is normal.
Mm-hmm.
So I think this is normal. It's just a ganglionic cyst in that region. Just going through the rest of the image. Okay, so there is a joint effusion and just trying to see the ACL. I can see that the ACL is intact, but there is significant marrow edema and soft tissue around the entire knee joint. So there's also bony contusion on the posterior aspect of the femoral condyle. Just trying to see the PCL. Apologies, it's just a bit slow.
Yeah, understood. It is a bit slow.
So the PCL looks intact. It's uniformly dark. Although the the femoral attachment, there appears to be discontinuity of the fibers there, but I'm just going to have another look at it. Yeah, so I'm concerned about the femoral attachment site of the PCL. Just going to, so yes, again, large joint effusion. And looking at the medial meniscus, that looks intact, although there is some high signal in the posterior horn, but again, it doesn't seem to be in contact with the articular surfaces, so I don't think it's a tear. I think it just might be some mucoid degeneration. Okay. So in essence, there is some meridema on the posterior aspect of the femoral condyle, and I believe there's an abnormality at the femoral attachment site of the PCL as well. So I'm just going to look at the coronal sequences now as well. So specifically looking at the PCL on the coronal view to see if it's normal. So the PCL looks fine actually because it's rounded and it's dark. Okay. So again, there is a cystic structure arising from the lateral knee joint, which I think we already established is a ganglionic cyst, and there was no evidence of a meniscal tear in that region. So I'm just trying to work out. So there is a significant meridema along the lateral femoral condyle. So I believe this is in keeping with a direct impaction injury, as opposed to a twisting injury. And you mentioned that the patient's a skier, so I'll be worried about a pivot injury, pivot shift injury, although that's more of the twisting.
A pivot shift injury.
Yes.
Suggest the ACL doesn't look. You've said the ACL looks fine. You've said the menisci look fine. You haven't said it, but you haven't said anything negative about the MCL. So how can it be a pivot shift if none of these structures is damaged? Just because he's a skier, poor thing, doesn't mean that he's going to end up with a pivot shift.
Yes.
Most likely, but then you've got to give me a proof of the pivot shift injury resulting in structural damage, which you haven't.
Sorry.
We can go back and can you see a little orange revert button? If you press that, it'll go back to normal. Yeah, that one. Reset. Top left.
This one?
Oh, hang on. Here you go. Oops, that's disappeared.
Sorry.
Oh, that's okay. Okay, give us a summary then, apart from pivot shift. Any other thoughts?
I'm just thinking of the normal contusion patterns. I mean, I'm a bit confused because there's significant marrow edema, but I've not seen any meniscal injuries or the ACL is intact. The PCL, I believe.
Sorry to barge in. We have lost your screen. Okay, it's back now. So please continue, candidate one. Please continue.
Sorry, I'm just trying to make sense of the findings.
That's fine. Sometimes in the exam situation, you can't make sense of things. That's absolutely understandable. So if you are stuck in a situation, you say to the examiner, these are my findings. I'm sorry, I can't really understand the mechanism. One of the possibilities is, as you've said, that there may well be a direct traumatic injury to the lateral side. That's absolutely fine. You know, there's only limited time and you can't be expected to give a full mechanism of injury. If you do, that's excellent. You only get extra marks. But let's just go through the case again. Let's go back to the lateral side. And we start with this particular image where you actually beautifully see the common peroneal nerve. Can you see that? So that's the normal course of the common peroneal nerve around the fibula neck. So, and sometimes if you damage the fibula, you can damage the nerve. This is the biceps femoris. There's a bit of high signal, but still seems nice and intact. The lateral collateral ligament seems intact. So you've got the Bugs Bunny, as you said. Now, all of this abnormality, what is the chance of me showing you two lateral contusion back to back? Zero. There's no way I'm going to show you exactly the same case again. So that means there must be, let's just keep looking. The lateral meniscus, you said, is abnormal initially because you thought the posterior horn was significantly smaller than the anterior horn. If you look at the anterior and posterior horn, there's not a huge amount of difference between the two. And remember, I always said, just correlate with the coronal as well. And you can see actually the lateral meniscus looks pretty good. Remember the last case I showed you where there was blunting? Look here, the triangle is maintained front to back. So the lateral meniscus is absolutely fine, as you very rightly said. We keep going forwards. And as we are going forwards, can you see that there is additional bone bruising? There's additional bone bruising coming in view where? Patella. You keep going, look at the bone bruising here. So that should immediately alert you to only one particular diagnosis. Whenever you see marrow edema of the lateral femoral condyle or lateral femoral trochlea, and you see corresponding marrow edema of the patella, you start thinking about transient lateral patellar dislocation, even without the axial. You haven't even looked at the axial yet, but if I see marrow edema of the patella, I see marrow edema of the lateral femoral trochlea or the lateral femoral condyle, the first thing which comes to my mind is a transient lateral patellar dislocation. So we need to now look at the case with this extra finding that we picked up, which is all of this. And remember, there's also something else which is not right. It is the shape of the patella here. It seems rather blunted. It should have an apex going all the way through. There's a bit of something abnormal visible here, but we'll confirm that once we look at the axial. So remember, now we are heading towards the medial side and you still see marrow edema. So that should immediately put you into a firm diagnosis that this is going to be a transient lateral patellar dislocation. So how do we confirm to see what else is going on? You also see that there is a little cortical break here. See, the cortex is generally black on almost all sequences, but if you see, the cortex stops here. So you need to be careful as to what's going on here. So let's just keep looking. I completely agree with you that the ACL looks fine, and I also agree the PCL looks fine, and the posterior joint capsule looks okay. The medial meniscus shows myxoid degeneration, as you very rightly said, because you've got the coronal sequence to look at, and there's convincingly no tear visible. You do see that there is a bit of myxoid degeneration. We've already said that the MCL is generally visible as a thin black line on the coronal. You can see that. Remember, there's a bit of joint effusion, so you will see a little bit of fluid in the recess, but it's nothing major. This is just part of the joint effusion which is visible. What's interesting about the joint effusion is what I want you to look at. Can you not see that there is a level here? There's a difference in the signal intensity of this fluid and this fluid because there's a vertical line, there's a horizontal line running through. Can you see it better now?
Yes.
This is liphemarthrosis, as you call it. This is a fat fluid level, implying that there's been a fracture, or at least there's some fracture somewhere. We don't know where yet. We just know that there is a fracture, and we are concerned about the patella. So we've confirmed that the menisci generally look okay, the cruciates generally look okay, the patella doesn't look right, and the lateral femoral condyle doesn't look right. We need to see the axial sequence now to see what's going on. Bring up the axial sequence, and that confirms your fat fluid level, liphemarthrosis, and here goes your transient lateral patellar dislocation. So this patella has actually gone, hit it here, come back, fractured the medial half of the patella. Look at the medial patellar retinaculum. It's diffusely thickened. This is how it should be. This is the lateral patellar retinaculum. This is a thin black line. You should have a similar sort of thing here. But what you see is diffuse edema, diffuse thickening of the lateral and the medial patellar retinaculum. So you have to now follow the medial patellar femoral ligament. Remember, I was telling you medial patellar femoral ligament. So this is part of the medial patellar femoral ligament, which actually doesn't look too bad, which is actually intact. But it's the medial patellar retinaculum which is torn. Now, what else happens when you transiently dislocate the patella? You sometimes can disrupt the cartilage, and most commonly the cartilage goes from here, because as the patella slides across, it degloves the cartilage from here and takes a piece of the cartilage, which is torn off. Or where the patella apex hit the bone, that's where most of the damage is. So what you can see here is that this cartilage is abnormal. See the black line? That's the cortex. Where is the black line here? You don't see it. And then you see the black line here again, which is the cortex. So there's definitely been an avulsion or some sort of bony injury of the patella apex with damage to the cartilage. And that's why you've got the fat fluid level. So what do? We need to find where the fracture is. What would you do?
Look at the T1s. Oh, sorry. Do a CT.
Do a CT, absolutely. Simple answer. Even if you do a T1, you wouldn't be able to be absolutely 100% sure. Do a CT is the correct answer in the exam situation. I've actually got a better is my screen still sharing or not?
No. So.
No. Okay, here you go. This is the X-ray of the same patient. Can you see a fractured fragment?
Yep.
So sometimes plain X-rays are really important because with this sort of injury, you can actually see an avulsed fragment already visible. And this is the fat fluid level that you can see. So CT is the correct answer, and you would have gotten full marks for that. So remember, I've shown you 3 different patterns of bone marrow edema, completely different mechanisms of injury, completely different things to consider and think in your mind. Just by looking at the pattern of bone bruising, you've actually reached the potentially reached the answer as to what would have happened, because then you'd be able to tell the examiner what are the structures which get damaged. If you don't pick up the marrow edema of the patella, you'll never tell them that this is a transient lateral patellar dislocation. You'll never tell them that there's damage to the medial patellar retinaculum. You'll not tell them that there is an associated fracture or cartilage damage to the patella. Is that okay?
Yeah, that's excellent. Thank you very much.
Okay, stop sharing. Last short case. for candidate number 2, and then we're done. I don't know about you because I've had it. So we'll go to, here we go. I'm going to get candidate 2 now. I'm going to share the screen first. Remote control. Candidate 2 still there?
Yes.
There you are. So this is a middle-aged person, about 45 years of age, and was playing excellent golf, but then suddenly presented with swelling and pain in the knee and could not continue beyond the second hole.
Okay, so on the sagittal PD fat set sequence, I'm looking at the lateral compartment and the bicep femoris and lateral collateral ligament tendons appear intact. The quadricep tendon is abnormal, and there appears to be tear in the muscle with a large joint effusion. Just look at the patella. There's no bone marrow edema of the patella. The lateral meniscus is normal. I'm just looking at the ACL. The ACL and PCL appears intact. So the medial meniscus is abnormal. There's cannot see at least 2 bow tie, which suggests there may be a bucket handle injury. And the posterior horn of the medial meniscus is also truncated, as well as that the proximal tibia, where the posterior horn is attached, is abnormal. There appears to be maybe a fracture fragment, but it's very difficult to characterize on the PD fat set. So I'll look at that on the T1 if that's available later. Mm-hmm. And there's more joint effusion posteriorly with the capsule looks distended and swollen, and the popliteal vessels appear normal. So I'll look at the coronal view now. I'll start anteriorly. There's some high signal in the medial tibial plateau with a fracture fragment. And the anterior horn of the medial meniscus is, that's okay. I'm trying to trace it back to posteriorly to confirm whether there was a bucket handle injury and to find the displaced fragment. Which is usually an intercondylar notch, but I'm not seeing it.
Okay, good.
I would like to look at the axial view just to confirm if there is quadricep tendon or muscle tear.
You've got the axial.
So there's significant high signal in the quadriceps tendon, which is in keeping with a rupture.
Okay, so in summary?
So in summary, there is a bucket and no injury of the medial meniscus and complete rupture of the quadriceps tendon and a fracture fragment of the medial tibial plateau.
Okay. Okay, good. So, so remember, you can get muscle injuries around the, or tendon injuries around the knee, which is very easy to miss, especially if they've done a very tight field of view images. Sometimes you may come across extremity scanners in which the field of view is round and it's quite limited. So generally speaking, if you've got a standard 1.5 Tesla machine, chances are that you would normally cover the distal quadriceps entirely easily. So there's no chance of missing that. So you're absolutely right. You picked this up very well, because there is a high-grade tear of the quadriceps tendon. Now, the important question is it a full thickness tear or a partial thickness tear? Because there are implications. If it's a full thickness tear, it requires surgical repair. If it's a partial thickness tear, it may just heal. So in your summary, you just cannot say that there is a tear. You have to quantify it one step more for the examiner or for your surgeon. If this was a case in your department, the first thing the surgeon is going to ask you, do you think it's a full thickness tear or a partial thickness tear? Did I hear anything from you on those accounts?
I said full thickness, but not in the summary.
Now, are you sure it's a full thickness? Just looking at this, I can easily say to you, but I can still see some tendon fibers.
Other than that single tendon fiber, I think most of it is gone. So I would say this is high grade and
So now you're changing your diagnosis to a high grade partial thickness tear. Is that right?
Yes.
Or are you saying still a full thickness tear? The reason I'm asking you, I'm pestering you for a reason. The reason is sometimes we can't be sure on MR. You have to do an ultrasound exam. Ultrasound is really important for tendons, especially the extensor mechanism, because ultrasound is superb in picking up patella and quadriceps tendons disruption. If you were to do an ultrasound, you'd easily tell us if there is any fiber which is intact or not. Now, if there is a central fiber which is still intact, you may have actually disrupted the tendon on either side, but the central tendon is still holding the quadriceps at the superior pole of the patella. So they may just treat them conservatively. Remember, this is a middle-aged man. He's not going to go out and, if he was a footballer, they'd probably go in and repair it. But for somebody, why do you say I gave you the, even if you look at the medial compartment, even if I don't give you the age, this is not a young knee, is it? Because if you look at the compartments, just bring up the coronal on this side. So what you notice here is that this patient has got osteophytes. So on the medial side, there has been an ongoing degenerative process going on. So this is a long-standing, or this is not an acute tear, this is a degenerate tear. What sort of a tear? You didn't mention, did you mention what? Of course, just tear is one thing. Then you have to tell them, whenever you describe a tear, you have to tell them 3 or 4 things. First, is there a tear? What sort of the shape the tear is? Is it an oblique tear? Is it a radial tear? Is it a horizontal tear? Is it a complex tear having more than 1 bits? The third thing you've got to tell them is where is it? Is it at the front, the anterior horn? Is it at the junction of the anterior horn with the meniscal body? Is it the meniscal body itself? Is it the junction of the meniscal body with the posterior horn? Is it the root of the posterior horn on the medial meniscus? So all of these things, whenever you start describing a tear, you have to mention these 3 or 4 things, because the examiner will immediately know that you've looked at knee MR scans. You know what you're talking about. So if you look here, just on this particular sequence, this is a pretty abnormal shape of the medial meniscus. It's blunted, it's extruded, so it's definitely a degenerate radial tear of the body of the medial meniscus. The meniscal root is degenerate because you can see there is abnormal signal. Look at the root hair, nice and black. Look at the root hair, white or gray-white, which means that the root is degenerate. The tear involves the peripheral third of the posterior horn of the medial meniscus, because remember, this is the posterior horn. And as we come forwards, you can start seeing the anterior horn, which looks more okay. So the tear is primarily meniscal body and posterior horn junction. And as a result, there's a bit of extrusion because of this radial tear. There's no bucket handle tear. For bucket handle, you need to see an extra fragment lying here, which you actually did mention that there wasn't. You could not see a bucket handle flip meniscal fragment. But most of the time, what happens is because the tear is here, the meniscus extrudes out. So this is a complex tear of the medial meniscus. And because of this extrusion, this irritates the deep MCL. This is called deep MCL synovitis. See, this is the superficial MCL. You see fluid in the deep MCL recess both around the meniscus above and below. This is quite typical of deep MCL synovitis. This causes constant pain to the patient. Even if the meniscus is repaired, if you don't do something about this, it will keep causing pain. So that then brings us to the quadriceps tendon. So quadriceps tendon repair ruptures, you must do an ultrasound, because remember, it'll give you an idea as to whether the central bit of the tendon is involved, or is it the vastus lateralis and medialis which are coming in. Most often you disrupt just one bit. Sometimes it's the vastus lateralis, sometimes it's the vastus medialis. Unless it's a transection injury, then you rupture the whole of the tendon. Just by twisting, it's very rare to rupture the whole of the quadriceps tendon. But you did extremely well because you picked it up. It's very easy to be bogged down by looking at these structures here that you don't actually look up here. So you did excellent to pick that up. So this is what this case was all about, for you to develop your eye to pick up the tendons, especially the quadriceps. So I think that's all I have to say today, Dr. Sunny.
Thank you very much. It was absolutely brilliant. And I am sure everybody enjoyed it. Everybody learned a lot.